Hello everyone, welcome back to my YouTube channel. In this video, we are going to discuss about antineoplastic agents which are used in the management of various cancers. So without delay, let's start the video. Okay, as you see here in this outline, we will see about a brief introductory part about cancer and the various genes involved in the development of carcinogenesis and the cell cycle, the transition from one phase to the other, as well as major mediators that regulate the cell cycle. It is a regulation, so we'll see. The other one is pathogenesis of cancer, especially the primary as well as the secondary tumor formation. So we'll see the pathogenesis. Finally, we'll see in detail different drugs that are used in the management of various cancer. Okay, before we start our video, please try to subscribe as well as like for more pharmacology related videos. Okay, very nice. By definition, cancer can be defined by a group of various diseases that is characterized by uncontrolled growth of less differentiated cells. This is mostly resulted from the shift in the control mechanism, especially that governs cell survival, proliferation, and differentiation, especially the genes involved in the tumor suppressions. If there is any abnormality like genes, tumor suppressor genes, P51 genes, if there is any abnormality, leads to development of cancer, as well as if the DNA repair genes failed to repair damaged DNA, this can also result in the development of cancer. And the various genes abnormality like retinoblastomas and other related mediators, if there is any hyperactivity, that can lead to for the development of cancer generally. So nowadays worldwide there are more than 200 different cancer identified. From this there are 4 cancer, most common cancer. The first one is hormone related. This is breast cancer. Both breast cancer as well as prostate cancer are among hormone related cancer due to the hormone effect on the growth. So this, especially the breast cancer in women, is mostly associated with the hormone estrogen, as well as this lung cancer associated with tobacco smoking, and the colorectal cancer, mostly related to the dietary factors and different factors. The other one is prostate cancer. This prostate cancer especially associated with androgen hormone, so especially is more prevalent in aged people greater than 50 years old. So these are the major 4 types of cancer. Here, what you should know is that in female population, the development of breast cancer is very high among males. This reason, the major reason, is that due to in females, their breast mass is very large. So that means they have estrogen positive receptors in high number, so this predisposes them to development of breast cancer. The other reason will be that in females, the lifetime exposure to estrogen will result in the development of cancer, especially after menopause. After ovary stops production of the estrogen, other aromatization reactions can predispose, also will continue to release estrogen, and this also can increase the development of cancer. Very nice. So in males, the risk of development of breast cancer especially at age greater than 50 is very high. So this result in prostate cancer due to androgenic effect, that androgen will act on the prostate gland and will increase prostate gland proliferation abnormally. This is mostly due to aging effect. Mostly as we age, our DNA is susceptible for the damage, and this damage or can result in mutation of DNA. This progress to the development of cancer. So the other one, life exposure to androgen leads to lifetime exposure to androgen leads to development of cancer in male. Okay, neoplasm is normally, that means tumor or cancer that can be originate anywhere in the body. That means it can develop somewhere in the body, and they can disseminate to other nearby tissues, and they can infect, can result in the development of secondary cancer. So we can classify cancer into two classes, especially solid tumor and the liquid tumor. So the solid tumor is organ tumors mostly, and the liquid tumor is a blood related cancer. So we can classify the solid tumor into two groups, the carcinoma as well as the sarcoma, based on the type of tissue that develop the cancer. So if it is the carcinoma, especially if the cancer derived from the or originates from the skin and from the tissue that covers the various internal organs. The other one is sarcoma. So sarcoma, especially cancer if arised from, or it's cancer if it's arising from cells that supporting or connective tissue, especially the cartilage, the muscle, the adipose tissue, and the different body parts that come from the starting or that originate from the connective tissue is said to be sarcoma. Liquid tumor can include the leukemia as well as the myeloma. So the leukemia is normally the bone marrow cancer, especially if there is a cancer in the bone marrow, so there will be leukemia. The other one is myeloma, and the lymphoma is immune cell cancer, like the B cells. So this is a classification of generally the liquid tumor. Let's see the next slide. As you see here, this is a list of curable cancer. Cancer is very challenging for chemotherapeutic agents to be cured, that to be targeted by various chemotherapy. There is very big challenge due to various reasons. But if there is early diagnosis, or if the cancer is detected in early, it can be cured. So this especially the young sarcoma, which mostly tumors that grow in the bone as well as around bone, the Wilms tumor, the in kidney tissues, or choriocarcinoma, especially the placental, the Burkitt's lymphoma that includes the non-Hodgkin lymphoma, that means non-Gantt cells. The other one is Hodgkin disease, which include with red Starbank cells, that means with Gantt cells. The other one is non-Hodgkin disease without red Starbank cells, without a Gantt cell. So seminomas, especially the germ cell tumor of the testicle, is called seminomas. Okay, let's see the cause of cancer. All cancer results from multiple mutation of DNA can result in development cancer, and can be further classified as cause as internal and external. So the internal factors or the internal cause for the cancer development is inherited mutation from the family history. So this only contains about 5 to 10% cancer, like ovarian cancer or the breast cancer is mostly inherited type of cancer from inherited mutation from the family history. The other one is environmental or acquired factors. So this contains includes majority of the cancer nowadays diagnosed. So which the first one is tobacco. Tobacco especially can result in the development of lung cancer, the mouth cancer, esophagus cancer, and as well as in especially can result in bladder cancer associated with tobacco. The other one is diet, especially processed meats, highly processed meats, fabricated food products, as well as low dietary fiber, and consuming high fat foods can predispose to cancer or increase the likelihood of development of cancer. The other one is exposure to radiation. When you exposed to the sunlight or UV light, this can result in the development of the especially skin cancer. Also, radiation therapies sometimes used for the management of cancer, as well as for various diagnostic purpose, can result in DNA mutation, can result in DNA damage. This can also increase or lead to development of cancer. Here on the diet, you should know is that this diet related foods or consuming those foods, what I have mentioned earlier, can lead to colorectal cancer, stomach cancer, and the different intestinal cancer can be caused by those foods, consuming of those highly processed foods. The other one is infectious organisms, especially the human papilloma virus can result in cancer, the cervical cancer, as well as H. pylori can result in gastrointestinal cancers. The other one is alcohol consumption. Alcohol is very dangerous, so it can result in liver cancer, oral cancer, and a different type of cancer can be caused due to high consumption of alcohol. So these are the major cause of cancer, internal as well as external. Very nice. Here, as you see, various genes that are involved in the development of carcinogenesis or in the development of cancer. These are normally genes that regulate the development of cancer. Normally, these are oncogenes. Normally, oncogen is an abnormal gene or mutated genes from the proto-oncogenes. Normally, firstly, you should know about the proto-oncogenes. So, proto-oncogenes normally they regulate the cell transition from one phase to other. Especially, they can can stimulate cell proliferation in normal if there is a signal within the cell. That means growth hormone signals can trigger the proto-oncogenes. Proto-oncogenes can activated due to growth factor after activation, so they can stimulate the cytokine dependent kinase and cytokine complex formation. So this can lead to dephosphorylation of the retinoblastoma. Normally, the retinoblastoma is found in bound form with transcription factor E2F. This normally help the transcription factor normally can translocate into the nucleus, then can increase the transcription, and this result in cell growth or proliferation or DNA replication. So normally these oncogenes can prevent these oncogenes can increase the proto-oncogenes can increase complex formation of cyclin with the cyclin-dependent kinase, then cyclin-dependent kinase complex can phosphorylate the retinoblastoma. Upon phosphorylation, the bound form of the transcription factor can be released and can travel or translocate to the nucleus and increase transcription of the DNA. By this means, this can result in proliferation. But if there is a mutation in genes of the proto-oncogenes, this can lead to hyperactivity of oncogen, and they will be turned into the oncogenes or the abnormal genes. So this normally can increase the formation of cyclin with the cyclin dependent kinase. That means this increase the cell proliferation at high speed. So this can result in error and mutation. So result in abnormal cell formation or cancer. The other one is tumor suppressor genes. These tumor suppressor genes are also said to be guardian of the genome. This means they can prevent if there is any, they can identify any errors within the cells. If there is error, they can prevent any from continuing the cell to the next cycle, and they can induce apoptosis. Apoptosis, if there is any DNA damage, if there is any problem, they easily can trigger apoptosis, and they can save the host from any cancer. But normally, these tumor suppressor genes can code for proteins that regulate the cell cycles, like the P21 proteins that can prevent if there is any detected damage in the DNA, or if there is no signal. So if there is no any growth signal that trigger cell proliferation, so they will be activated and they can prevent any proliferation. So by this means, they can guard the host from developing any cancer. The other one is DNA repair genes. DNA repair genes, they mostly code for proteins, and they can detect any DNA damage within the cell. If there is DNA damage, they can fix, but if the DNA damage is irreversible, they can induce also apoptosis. But in the case of mutation, the DNA repair genes lack the ability to repair genes, and the mutated DNA will increase. So this led to development of cancer formation. So also the tumor suppressor genes abnormality can result in increased tumor formation, because this normally responsible for suppression of tumor. This diagram shows you normally tumor suppressor genes deletion or inactivation can result in development of cancer. This also diagram shows DNA repair genes. So normally DNA repair genes can check the DNA base pairs, their match, so they can, if there is any errors like thiamine with cytosine, if it is paired wrongly, they can easily fix like this. They change thiamine with the guanine, and with cytosine. So this is normal and no cancer will be developed. By this means they can easily fix. But in the case of then if there is DNA repair genes non-functional, so it cannot correct the error. So this led to development of cancer. This is normally typo error, but they cannot fix the issue, and the cancer will continue to grow. Okay, this is normally shows the cell cycle. Cell cycle, as you see here, contains the interphase normally, which contains from G1 to the G2 phase, and the mitotic phase contains this part. Normally, interphase contain this part. So normally in the G1 phase, the important nutrients, proteins, and enzymes are synthesized to support the cell growth in the G1 phase. After this process is done, or after the preparation is complete, and if there is sufficient for the next division to occur, so it will transit to the S phase. But between the G1 and the S phase, there is checkpoint regulators or checkpoint, so they can detect if there is any problem, so they can prevent from transition from G1 to the S phase. After the cell is transited, after the cell enters into the S phase, it will replicate its DNA material. So there will be there will be replication, especially through semi-conservative method. After that, if there is no any DNA damage, it can transit from the S phase to the G2 phase. Within G2 phase, so the cell prepare for the next division. So that means it will increase in the size and increase its cytoplasm, but there is no other process here. After preparation of various enzymes as well as proteins that are involved in the production of microtubules. So if there is no error, or if there is no any problem, so the cell can easily transit from the G2 phase to the M phase. Within M phase, there is microtubules formation, and as well as there will be daughter cell formation. The cell will divide and then will leave the M phase. By this means, the cell will grow and increase in number. This is the process from G1 to M phase. Here, what you see is that normally within the cell cycle, there is a control system, or the security guard within each three different areas, starting from the G1 to the G1 to the S phase. From the G1 to S phase, there is a guard that makes sure if there is favorable condition for the cell to move from G1 to the S phase. If any problem is detected, if there is no any favorable condition, that means if the produce enzyme and the protein are not sufficient for the cell to move to the next cycle, so they can prevent the cell from moving. This especially are regulated by these key players like cyclins, cyclin-dependent kinase, tumor suppressor genes, and especially the P53 and the retinoblastomas. Normally, for the transition, the cyclins and the cyclin-dependent kinase play important role in transiting the cell from the G1 phase to the S phase for growth, if condition is favorable. But if the condition is not favorable, the tumor suppressor genes can prevent the cell from the transition from the G1 phase to the S phase. So once the cell is within the S phase, it will replicate. So and normally also these normal DNA repair genes as well as the tumor suppressor genes can detect if there is any problem or any DNA damage. If there is any DNA damage, they can induce the cell to be apoptized and result in suicide of the cell, and they can limit the development of mutagens. So if there is no any DNA damage, so the cell can also continue to transit to the from S phase to the G2 phase. Within G2 phase, the cell there is after it entered into the G2 phase, then it there is also other checkpoint or guards. So from G to M phase, as you see here, there is a security guard that control entry of the cell from the G2 to M phase. So if there is no any DNA damage, so the cell can transit to the M phase. Also here, as you see, once the cell is in the M phase, there is also other checkpoint within the M phase from the metaphase to the anaphase. So transition can be regulated by further by the mediators, various mediators. So if there is no any errors, so the cell can able to transit and to further phase, and can divide into two daughter cells, and can continue its growth or its proliferation. This is the mechanism by which the cell cycle is governed. Very nice. This is a pathogenesis of cancer. Okay. Firstly, there are different factors like environmental factors that are responsible for the development of cancer. The first one is chemicals, virus exposure, and radiation like sun exposure. Chemicals like benzene exposure can result in acquired mutations. Already we have discussed this, and inherited mutations like deletion of the tumor suppressor genes, and also it can be due to DNA repair genes alteration, can result in the development of cancer. So combination of these factors, the acquired mutation with the inherited mutation, can lead to progression to the cancer. So this factor leads to proto-oncogenes to be changed into the oncogenes, to the abnormal genes. So this in combination with promoters like the hormones which have role in the in initiation of cancer in the presence of the initiators, as well as co-carcinogens has the ability to induce cancer with collaboration with the presence of the carcinogens. So this factor totally can lead to uncontrolled cell proliferation and the differentiation, especially in formation of the undifferentiated or stem-like cells. So they can easily re-enter to the cell cycle, and they can replicate more. The other one is this leads to apoptosis and the alteration in the telomeres. That means this decrease can decrease the apoptosis, so that can increase the cancer number or cancer cells number. The other one increase in polymerase activity, or this enzyme leads to immortal cancer cells. So this can further go into the cell cycle and replicate, then resulting development of primary tumor. This primary tumor is localized within a specified area, so it can also infect nearby tissues. So let's see. So development of primary tumor followed by the production of metalloproteinase. Normally, metalloproteinase are enzymes synthesized by the cancer or tumor cells, which normally can degrade the cellular matrix as well as the basement membrane. The basement membrane and the cellular matrix that restrict the cells from invading nearby tissue, or that make the cell to be localized within its destination, so it cannot escape its area. But the metalloproteinase activity can lead to destruction of both cellular matrix as well as basement membrane, so the cell can easily escape its destination or its restricted area and can invade the nearby tissue cells. So this can lead to angiogenesis. So angiogenesis, especially formation of new blood vessels to supply tumor cells with blood as well as nutrient. This is normally mediated by the increased secretion or production of various growth factors, like the epidermal, the growth factor, vascular epidermal growth factor leads to increased production of blood, new blood vessels that supply the tumor. The other one is metastasis. The metastasis normally is invasion of the nearby tissue as well as entering into the systemic circulation, and this can result in development of the secondary tumor. The secondary tumor formation is mostly achieved by entering into the systemic circulation. This can be very fatal for the host. Okay, very nice. Okay, now we'll see about cancer medication or antineoplastic drugs very in detail. Okay, the first the goal or the major aim of anti-cancer medication, cancer treatment will be, if possible, it will be total eradication of cancer or curative. That means to destroy all remnant or residual cancer remnants within the host, so to destroy any relapse or to prevent a relapse, and to achieve eradication of all cancer remnants. So this can be achieved by giving a combination regimens that act by different mechanism of action, as well as that drugs have different toxicity, so to avoid any harm to the host. So if the curative therapy is not possible, so the second choice would be the palliative treatment. This palliative treatment is only symptomatic treatment. That means only alleviation of symptoms, only any reduction of symptoms associated with cancer, especially improving quality of life and increase pain-free days, as well as sometimes to extend the life of the patient. There is a major challenge or problem associated with the use of chemotherapeutic agents. The first one is resistance. Resistance is a major issue. It can be either acquired resistance or inherited resistance, especially the acquired resistance, especially the inherited resistance. It's due to decreased permeability, especially related to solid tumors. Solid tumors by nature, they are intrinsically resistant for entry of any chemotherapeutic agents, as well as acquired resistance after exposure to the drug. The drug can easily activate various enzymes that deactivates the drug, as well as that increased expression of various transporters that efflux out of the chemotherapeutic agents. So the other one is multi-drug resistance. The multi-drug resistance mostly caused when various different chemotherapeutic agents with different mechanism of action cannot able to cure the cancer, or the cancer cell become resistance for the various different chemotherapeutic drugs. So this can be achieved, for example, by increasing the expression of proteins that pumps the chemotherapeutic agents out of the cell. For example, the P glycoproteins is the one who pumps out chemotherapeutic agents out of the cancer cell prior to reaching the DNA. So the other one is toxicity is a major challenge, because selective toxicity to the cancer cell is very difficult to achieve. So normally the chemotherapeutic agents can affect both the host as well as the cancer significantly to the cancer cells. Will have high toxicity, but besides that, it will have also effect on the normal host cells, because the normal highly proliferative tissues are highly susceptible for the destruction by this chemotherapeutic agent. The other one is treatment-induced tumor. So some chemotherapeutic agents like alkylating agents can induce or result in secondary tumor after treatment of after 10 years, and tamoxifens also can cause the endometrial cancer. Some, as well as radiation therapy, can result in DNA damage, and further can result in development of secondary tumor. This is very bad. Okay, here the concept of total cell kill is to destroy all residual or all the cancer cells within the host. This is normally achieved through combination of different chemotherapeutic agents. So this can prevent recovery, and the result can prevent relapse and prolong the patient life. Here is important concept that shows this diagram shows the theoretical growth of cancer cells. This Gompertesian growth curve, normally curve that shows the growth of the cancer cell. So as you see here, it starts from here. So initially the cancer cells grow very slowly, and this is a lag time. So this is because there is fight between the cancer cell and the immune system. So after many struggle, so the immune system is defeated by the cancer cells. So once it's defeated, so it will rise, as cancer cell will rise exponentially, will increase their number. So it can increase exponentially. So that means it will have high growth fraction. So that means it will have short doubling time to replicate itself twice. Within short period, it can double itself. So once the cancer cell reaches 1 billion cell, it can be diagonized, or it is detectable. So it's about 1 gram, so it can be easily detectable, but prior to that it cannot be detectable. But patient remains asymptomatic, or most symptom cannot be developed. But here the concept issue now is that treatment, early detection of the cancer, and starting of the chemotherapeutic agents is very important thing, because in early phase there is rapid proliferation, rapid growth, and there is short doubling time. That means there will be the cancer cell is very highly dividing. So most chemotherapeutic agents targets highly dividing cells. So this detecting at this level led to chemotherapeutic agent success, increase the success rate, and can result in cure. But if we fail to diagnose or detect early, this normally, when the cancer cell increase in the size, and if it is greater than 1 trillion, this can lead to plateau growth phase. This means normally the cancer become non-dividing, and it become divide very slowly, because the scarcity of the available nutrient and the blood supply due to increased size. So to avoid any further damage for its any damage, so the cancer cell can divide very slowly, so it's not vulnerable or targeted by various chemotherapeutic agents. So this become very challenging. So our treatment modality will be only symptomatic treatment or palliative treatment at this stage. Mostly we recommend early detection and combination of regimens within less than 1 billion cells of the cancer cell fraction. Here, the concept, as you see here, is the concept of adjuvant and neoadjuvant chemotherapy. When we say adjuvant chemotherapy, especially given after surgery or radiation, is mostly to destroy any residual micrometastasis, or to prevent any remnant cancer cells from developing a secondary cancer. So this is mandatory, giving adjuvant chemotherapy after the surgical procedure or radiation therapy. The other one is neoadjuvant. The neoadjuvant chemotherapy mostly are given in order to shrink the cancer and to facilitate the surgical procedures, to decrease the size of the tumor, and this facilitates surgical procedure or process, and to increase for exposure for radiotherapy. So after neoadjuvant, so we will continue with adjuvant chemotherapy after neoadjuvant. Okay, here classification of anti-cancer medications. There are different classification methods, but we'll see the general classification methods. To see as general, the anti-cancer medications can be classified according to their chemical structure they contains, like nitrogen status, different platinum compound, and different can be classified based on its chemical structure, as well as based on the source, like plant derivative, like alkaloid anti-cancer medications, based on biochemical mechanism, like antimetabolites, and the different medications can be categorized. And the other one is based on its phase of cell cycle, as cell cycle specific and non-cell cycle specific, based on where it acts. So classification based on phase according to the cell cycle or phase, as cell cycle specific medications like alkylating agents are the most common, as well as antibiotics. This cycle non-specific drugs can act on the G0 phases or non-dividing cells, as well as on the dividing cells, can act on either, and they are not selective. So they are destructive at both phases. So the other one is cell cycle specific agents, which act on specific phase of the cycle. Example, drugs that act on the S phase, like antimetabolites, specifically they affect DNA, so they act on S phase. The other one, M phase drugs, especially that act on the microtubules that prevent polymerization. So this can prevent any formation of microtubules like Vinca, Alkaloid, and HC. The other one is drugs act on the G2 phase, specifically bleomycin. This normally is antitumor antibiotics. So this is a classification. The other one is a general classification of anti-cancer drugs. So like alkylating agents that add alkyl group, antimetabolites that normally resembles normal metabolites, natural metabolites, anti-tumor antibiotics that is in the management of cancer only, but not indicated for any infectious disease, and they are very highly cytotoxic. The other one is alkaloid. Alkaloid are normally plant derivative. The other one is hormone receptor antagonist or hormone synthesis antagonists. We'll see. The other one is classification is immunomodulating drugs that potentiate the immune system, but by themselves not induce any cytotoxic activity. Very nice. Okay, now we'll see individual agents. The first group is alkylating agents. These alkylating agents generally have the same mechanism of action, all, and they are classified into various wide groups or based on their chemical structure they contain. So the first one is platinum-based compound, alkylating agents like cisplatin, carboblastin. The other one is nitrogen mustardes. These drugs normally originally was discovered during by observing the effect of their effect during World War I. Individuals exposed to the mustard gas suffered from the bone marrow toxicity, as well as the lymphocyte tissue damage. So after that, these nitrogen mustard derivatives discovered. Normally, these nitrogen mustard derivatives are less toxic than the mustard gases, and they are nitrogen mustards are very water soluble, but and they are solid, but the mustard gas are very highly toxic and they are water insoluble. The one example of the nitrogen mustard is the cyclophosphamide, mecloritharamine, the mustine, the ifosfamide, and the chlorambucil are the prominent example. The other one is nitrosoureas. This nitrosoureas, these drugs include the carmustine, lomustine, samustine, and the different drugs are categorized under this classification. These drugs are very highly non-polar, and that means they can achieve high concentration within the cerebrospinal fluid as well as within brain. So this makes them ideal for the management of various brain tumors or brain cancer, and they also can be used in the renal carcinoma as well as for the colorectal cancer and the different cancers. The other one is alkylating agents. Alkylating agents like the busulfan. The busulfan, this specially these medication are used in the palliative care, used especially in the leukemias, symptomatic relief. This especially drugs has high preference to the bone marrow, so they can alleviate symptoms to like spleen megaly or spleen, can decrease the spleen size, and mostly used in the management of palliative care management. And these drugs increase the likelihood of development of the uric acid level can increase by this drug. So gout is a major risk factor, or a major risk. So combining with allopurinol or the antioxidase inhibitor is mandatory or recommended to avoid gout development. The other one is ethylenamines. So this contains tiotepa. The tiotepa normally used in the ovarian as well as breast cancer. Okay, now we will see the general mechanism of alkylating agents. All, as I mentioned earlier, all alkylating agents has the same mechanism of action generally. So the alkylating agents have the ability to add the alkyl groups, especially ethyl, propyl, and methyl groups, to the many electronegative groups, especially to the oxygen as well as to the nitrogen group, to the nitrogen. So under condition present in the cell within the nucleus of the DNA, so they can add the alkyl group. So this means they can result in inter and intra strand breakage within one strand or within two strands. So they can cross-link both strands, or within one strand they can cause cross-linkage, and this can affect DNA unwinding. So this can result in DNA damage, so further can result in failure of further replication. As you see here, this mechanism shows how alkylating agents work. The alkylating agents, once enter into the body, so they form a highly reactive carbonium ion. They rearrange themselves, and they can this reactive carbonium ion is highly adhesive, or they can be easily attached to the DNA, so it can add the alkyl group to the DNA, the nucleophilic sites. So this can result in cross linkage. That means within the DNA, within one strand or within the two strand of the DNA can cross linkage, and this can affect unwinding and decrease cell replication, and this can result in inhibition of proliferation. Finally, can result in apoptosis. The other one is abnormal base pairing. So if there is abnormal base pairing, that means DNA cannot continue. So this result in mutation. So they introduce mutation, leads to apoptosis of the cell. The other one is DNA strand breakage. So if there is strand breakage, so the DNA repair genes will be activated and try to fix the break strand. So this may be failed to be repaired and can induce apoptosis, so generally lead to decreased cell proliferation. But by chance or as a side effect, alkylating agent can affect the host cell through affecting or damaging the RNA as well as proteins. This is how the intrastrand breakage within the one strand. This shows, but this shows this is one strand, this is the other strand. So between the strands there will be cross linkage, abnormal base pairing. So this result in DNA damage. So this can affect unwinding. The other one is drug resistance. So let's see how alkylating agents develop drug resistance. The first one is due to increased permeability. Due to increased expression of various proteins, especially DNA repair proteins overexpression. So this leads to decreased apoptosis. The other one is decreased permeability of the alkylating agents into the DNA. This is due to P-glycoprotein formation that pumps out the alkylating agents out of the cell. The other one is due to increased production of glutathione. So when you talk about glutathione, normally glutathione can conjugate form complex with alkylating agents. So formation of the glutathione with alkylating agents, the complex can be easily detectable or can be easily identified by immune cells, and prior to reaching the DNA, so the immune system will destroy the complex. So by this means they can continue the journey. The other one drug is platinum compound. The platinum compound. So the first one is cisplatin. The cisplatin, so which can be used in the management of various cancers like germ cell tumors, especially the germ cell tumors like the ovarian or the testicular carcinoma can be used, especially they can accumulate in the testes as well as intestine and kidney. So this makes them ideal for use of these agents in these cases. So they are especially high protein bound. That means they have high drug-to-drug interaction. If there is any concomitant drug that has high protein bound, so that means they can displace the cisplatin from their bounding site, and they can increase the toxicity of cisplatin. So care should be given. The other one is they have poor penetration to the blood-brain barrier, so they need intrathecal administration to avoid blood-brain barrier. The other one is low myelosuppression. So most chemotherapeutic agents associated with bone marrow toxicity is most common side effect. The other one is platinum compounds indications. They are indicated in the testicular, ovarian, and the bladder cancer, especially the skin cancer or the melanoma. The other one is what you should know is here the side effect associated with cisplatin is especially neurotoxicity is most common. So this can be avoided through giving IV salines or aggressive hydration or through giving virus diuretics like mannitols that can increase the removal of the drug through diuretic effects. So by this means we can manage the cisplatin neurotoxicity. The other one is nitrogen mustards. So include the cyclophosphamide. This normally the cyclophosphamide are a prodrug. They need metabolic activation once they enter into the body to give, especially with the CYP 450 enzyme, to give the aldophosphamide. This normally aldophosphamide is not active agent that give the therapeutic effect, but it needs further metabolism to give the phosphoramide mustard as well as the agrolin. Normally both the agrolin as well as phosphoramide mustard can have cytotoxic activity, but the agrolin is very dangerous and can result in hemorrhagic status or result in urinary bladder inflammation and damage. So acrolein should be given with Mensa as well as N-acetylcysteine to avoid any damage to the bladder. So normally acrolein is sulfhydryl donor. So normally Mensa and the acetylcysteine are sulfhydryl donors. So they form complex with acrolein and they make inactive acrolein. So there will be no any further damage. So indication of the acrolein, the cyclophosphamide in the Burkitt's lymphoma, neuroblastoma, especially childhood associated neuroblastoma, early childhood. The other one is retinoblastoma, especially associated with retinal cancer and breast cancer. These are indications. So major adverse effects associated with the cyclophosphamide is the first one is, as I mentioned earlier, hemorrhagic status, especially in the given to avoid this condition through Mensa as well as N-acetylcysteine. The other one is alopecia, so mostly affects highly proliferating the hair follicles, so resulting in temporary baldness or hair loss in various body regions. The other one is this medication can directly irritate the GI. The esophagus can induce nausea, vomiting, as well as they can trigger the chemotrigger zone and result in nausea and vomiting. So the other parameter should be considered is liver enzyme. So the liver enzyme should be monitored to avoid further hepatic damage. So normally this medication or cyclophosphamide are given in cycles. So if they are given within this week, the other week should be free. That ensures recovery of the host prior to further exposure. So this is various route to give these medications. It can be IV, intramuscular, intraplurally, can be administered, so or directly into tumor. Very nice. So here, as you see, antimetabolites. Normally, these antimetabolites contain variety of groups like folic acid analogs like methotrexate, purine analogs like 6-mercaptopurine, and 6-thioguanine, and the pyrimidine analogs like 5-fluorouracil. These normally antimetabolites generally resemble natural metabolites, so they are normally fake. The first one is folic acid antagonist. So the first one is methotrexate from this antimetabolite. So methotrexate, the general mechanism is that they normally resembles the structure of the folic acid, this methotrexate. So they resemble the normal metabolite of the folic acid. So they compete with the folic acid for binding site on dihydrofolate reductase. This enzyme is responsible for conversion of dihydrofolate into tetrahydrofolate or folic acid into tetrahydrofolate. Normally, the tetrahydrofolate is responsible for the transfer of one carbon unit for the purine as well as for the thymidine synthesis. So this normally purine and thymidines has important role in building block of the DNA. So if there is scarcity, so there will be no thymidine as well as purine. So this means there will be no any DNA synthesis. So there will be termination. So the cell cannot proliferate. By this means the methotrexate can act. Here is an important concept you should know. The first one is that once the methotrexate enters into the body intracellularly within the cancer cells, it can be polyglutamate or conjugated with glutamate, they form polyglutamate or metotrexate polyglutamate with enzyme polyglutamate synthase. This enzyme normally conjugate metotrexate with glutamate and form metotrexate polyglutamate. This normally polyglutamate synthase enzyme is mostly synthesized within the tumor cells in greater number than the normal cells. This is to increase the folic acid amount, because the polyglutamate normally trap folic acid within tumor cells to use for it is in the DNA synthesis or purine and the pyrimidine synthesis. Then for the DNA synthesis, they mostly use folic acid. So they to trap the folic acid within the cell, within tumor cells, so they increase the expression of the polyglutamate synthase enzyme. But this enzyme is not much more synthesized in the normal cells, but expression is increased in the tumor cells. So after the metotrexate is trapped within the tumor cells after formation of metotrexate polyglutamate or polyglutamate, they can irreversibly or they can permanently deactivate the enzyme tetrahydrofolate reductase enzyme, because they cannot escape the cells due to their complex formation. This has a beneficial role for the metotrexate mechanism of action, because it can act for prolonged time within the cell. So the pharmacokinetics profile, when you see, is normally highly polar, so it cannot achieve high concentration within the brain or cerebrospinal fluid. So to avoid this, we mostly give intrathecally to bypass. The other one is that they trapped within the cells by the polyglutamate synthase enzyme by glutamination or by forming conjugation. So they trap forever there, so they can act for prolonged period of time. The other one is contraindication, is renal impairment. Normally, these medications, metotrexate, is mostly excreted through urine or through kidney. So that means its most common means is excretion is totally through urine. Means if there is any renal impairment, so the drug will be concentration will be increased in the blood, so this can result in toxicity further. So to avoid this, mostly we should alkalize the urine to increase removal. We'll see it on the next slide. So metotrexate normal indication will be choriocarcinoma, especially placental cancer can be used because placental tissue are highly regenerative. So if there is cancer there, so we can easily target with metotrexate. But the other indication of metotrexate is the ectopic pregnancy, especially for termination of pregnancy out of the normal uterus, especially in the fallopian tube. So we can use metotrexate that can decrease the blood supply through the placenta to the fetus, and that can increase expulsion of the fetus. So the other indication is meningeal metastasis. Can be metotrexate can be largely used. The other one is adverse effect. So the major adverse effect associated with metotrexate is myelosuppression. So this increases the likelihood of development of infection. Risk will be increased. The other one is gastrointestinal disturbance. due to effect on highly proliferating gastrointestinal tissues, so can result in disturbance. The other one is renal toxicity. This mostly due to crystal urea formation. The crystal urea formation results from metabolites, especially methotrexate metabolites. The 7-OH methotrexate metabolite is less soluble than the methotrexate. So this means it should be given with large amount of water to increase its solubility and to ease its passage through the urine. And also, normally, the methotrexate and the 7-OH metabolite is normally weak acid. So weak acid should be in order to facilitate removal of weak acid. We should give with or we should alkalize the urine with sodium bicarbonate using sodium bicarbonate. So if you use sodium bicarbonate, the 7-OH metabolite become ionized. So ionized form cannot be reabsorbed. So it facilitates removal. The other one is leucovorin rescue regimen. Leucovorin, so especially associated with a high dose of methotrexate. So we should give to rescue the host from folic acid deficiency. So we give leucovorin. Especially leucovorin is not transported much more in the cancer cells because cancer cells lacks leucovorin transporters. So this make sense that leucovorin rescue regimens can successfully save the normal cells. The other one is all anti-cancer medications are teratogenic, so they are not indicated during pregnancy, but risk and the benefit should be checked and analysis is made prior to giving. Especially if you want to give, you should give after the second and the third trimester. The other one is purine antagonists. Purine antagonists. This contains 6-thiopurine associated mercaptopurine and the 6-thioguanine. The 6-thiopurine contains both drugs. So let's see each. Okay, the 6-thiopurine or the 6-mercaptopurine normally after it enters into the body, it needs metabolic activation to the 6-mercaptopurine ribosphosphate through the enzyme hypoxanthine guanine phosphoribosyl transferase. This after the conversion, so this normally 6-mercaptopurine ribosphosphate resembles the purine, so they can incorporate into the RNA and the DNA and result in non-functional RNA as well as DNA. So finally arrest the cell cycle and induce apoptosis. The other science here is that the metabolism of 6-mercaptopurine can result in 6-thiouric acid through the enzyme the antinoxidase. The antinoxidase normally metabolize 6-mercaptopurine into the 6-thiouric acid. This means this increase the likelihood of development of gout, can increase the risk of gout. So because can raise normally the 6-mercaptopurine become inactivated into the 6-thiouric acid. This is normal for the removal of the 6-mercaptopurine means. But in some patients who are comorbid with gout, so if they are taking the antioxidase inhibitor like allopurinol, the dose should be of 6-mercaptopurine should be reduced by the 25%. The other one is 6-thioguanine. This is this effect is not associated with the 6-thioguanine because they are not metabolized by the antioxidase. Especially indication of 6-mercaptopurine is early childhood acute leukemia. The other one is pyrimidine antagonist, especially the 5-fluorouracil and the capecitabine. Okay, let's see the mechanism of action of generally the 5-fluorouracil. Normally, once it's entered into the body, once inside the body, so the 5-fluorouracil is converted into the fluorodeoxyuridine monophosphate by so converted into this metabolite. Then this can affect the enzyme, the thymidylate synthase enzyme, which is responsible for conversion of the deoxyuridine monophosphate conversion, which is important. So this deoxyuridine monophosphate is important for thymidine monophosphate synthesis. So this normally can important role in the DNA synthesis finally. So this normally the fluorodeoxyuridine monophosphate can prevent the thymidylate synthesis. So there will be no DNA synthesis. By this means the 5-fluorouracil can act. Okay, generally indication include leukemia, gastrointestinal tract adenocarcinomas, as well as breast and ovarian and malignant lymphoma. Okay, very nice. Here we'll see antitumor antibiotics, especially can be classified into two, the anthracycline and non-anthracyclines, like the dactinomycin, mitomycin, daptomycin. So the first one is anthracyclines, especially doxorubicin and daunorubicin, effervescin. So this normally associated with severe side effects or toxicity. Mostly we do not recommend these medications. So mostly they result in cardiotoxicity due to they can form complex with iron within the cardiac tissue. So after forming, they reduced to form highly reactive species like reactive oxygen species. This can result in mitochondrial damage to the myocardium. So due to lack of sufficient antioxidant in the kidney, in the heart, this heart to be susceptible for these drugs. So these drugs are not recommended. The other one is non-anthracyclines are recommended, like dactinomycin and mitomycin has no such side effect and recommended. But the other one is bleomycin is associated with pulmonary fibrosis. So in the case, it also should be used in caution. Okay, let's see the major antibiotic mechanisms. Tumor antibiotic mechanism of action. The first one is they can disrupt the topology of double helix structure. So this means through intercalation between the DNA bases, they can add it up within the DNA strands. So base strands. So can change the topology and finally cause inhibition of the DNA polymerase, and the DNA dependent RNA polymerase. If the effect on the DNA polymerase can prevent replication, and DNA dependent RNA polymerization can affect the RNA synthesis. The other one is, as I mentioned, through production of free radicals through formation of complex with iron. So they become reduced. So they can result in oxygen reactive species production. So result in mitochondrial damage. This also can cause cytotoxic activity on the other hand on the cell, besides its adverse effect. That's one indication. So skin cancer and the various Wilms tumor, especially the kidney cancer. The other one here you see plant derivative plant alkaloids, especially the vincristine, vinblastine, and the vindesine. So these are plant derivative and taxanes like the paclitaxane. So this all can be, especially the alkaloid derivatives, especially the Vinca alkaloids, affect the microtubule formation. So especially in the late M2 phase or in the late G2 or the MV phase, so can prevent polymerization of microtubule. So that this can prevent any further cell division. So the other one associated with the paclitaxel, this can freeze the depolymerization. They can prevent depolymerization, or they result in freezing of the tubules. So they also can affect at the M phase. The other one is indication, so they can be indicated in the testicular as well as leukemia. But this totally can result in peripheral neuropathy, because this affects the M2 phase, so can affect the axonal transport. So if they affect the axonal transport, they can result in nerve damage, or neuropathy can be occurred. This is a mechanism. So this alkaloids can affect transition from the metaphase to the anaphase, as you see on the in this diagram. So from metaphase to the anaphase, so there will be polymerization in order to separate the chromosome. These chromosomes, as you see, it's successfully separated this chromosome and to this chromosome to the opposite side of the pole. But in the case of the medications, so they disrupt this normally, result in tubulin molecules fail to polymerize. So this result in dissolution or non-functional cell to become. So this result in failure for the cancer. Let's see hormones. Very nice. So hormones. The first one is normally, generally, hormones can act like a signal that triggers cell proliferation through acting various receptors. So we can antagonize these effects by hormone antagonists, by giving drugs that act on different receptors that can prevent the formation or proliferation. So the first one is anti-estrogen, tamoxifen. So tamoxifen is especially drug of choice in the postmenopausal women. So breast cancer is due to lifetime exposure to estrogen, especially estrogen. There is estrogen receptor on the breast. So when estrogen act on the breast cancer, on the breast tissue that act on the receptors, on estrogen receptors. So this can act like growth factor and can trigger proliferation. So generally, tamoxifen can antagonize this effect, so can prevent the estrogen normal from binding to the estrogen receptor in the breast tissue. Then they can prevent tumor formation. But the tamoxifen can have different effect on different tissues. The first one is on the liver. It will have agonistic activity. That means it can trigger the clotting factor synthesis or increase clotting factor synthesis. By this means they can easily increase the development of thromboembolism, so due to increased clotting factor formation. The other one is on the bone. They can increase the bone mineral density. Also, they have agonistic activity. It's positive. It's not as a side effect. But the other one is that they can also act as agonist on the endometrial tissue. So this can result in, as you see, endometrial cancer within the uterus. So can result in endometrial cancer. So this is the most unwanted side effect associated with tamoxifen, especially after long term use of the tamoxifen. After some time, the patient can develop endometrial cancer who are diagnosed with the breast cancer. So caution is recommended. aromatase inhibitor. So to avoid this, especially associated with tamoxifen, the endometrial cancer, in order to avoid that side effect, the aromatase inhibitors are the drug of choice, because the example letrozole, anastrozole, and other drugs, they can inhibit aromatization or estrogen synthesis, so they have no any risk associated with endometrial cancer, so they are preferred in the post-menopausal women. Mostly hot flash is due to estrogen withdrawal symptoms, and due to result in the hypothalamus thermoregulation zone disturbance. So these normally medications, as we see here, they decrease aromatization. Especially aromatization can occur in adrenal cortex, as well as from the liver, fat, and the different in the muscle can be aromatization process can be caused. So in this various tissue, so aromatization can be inhibited by aromatase inhibitors. So any source of the estrogen will be reduced. So this can also prevent the cancer development, especially breast cancer. The other one is anti-androgenic hormone antagonists like flutamides, the biglutamide. So these medications especially act on the prostate cancer. So they act on the androgen receptor on the prostate gland, so they can antagonize the effect of androgen. So by this means they can raise prostate cancer. Especially side effect associated with this medication is gynecomastia, especially due to anti-androgenic effect. So breast development in male is common, and decreased spermatogenesis and sexual desire will be decreased. Okay, finally, the ketoconazole is normally can be used in males to inhibit the production of especially androgen, to decrease source of androgen. Mostly this ketoconazole antifungal can be used, so they inhibit androgen production, especially testicular androgen production, so they can prevent those sources direct toxicity to prostate cells. This can prevent any mutagenesis. The other one is immunomodulating drugs that potentiate or boost the immune system by themselves. They do not induce any cytotoxic activity. For example, they include the interferons as well as the cytokines, interferon, and the cytokines. The interferon, the first one that increase antigen presentation of the innate as well as adaptive immunity. The other one, the interleukin or the aldesleukin. These medications, they can activate the T cells and the natural killer cells. After activation of these cells, they can fight against cancer cells. So this can be given with combination with other immunotherapeutic, with other chemotherapeutic agents. The other one is tritinon. So these medications, so they make cancer cell to become differentiated. That means they make the cancer cell to be functional. So this means they can decrease time to cancer cell to survive. The other one is feature robotic technology to treat cancer. So this normally to deliver the medications directly into tumor cells without causing any other toxicity with unwanted cells. So they can targetedly attack the cancer cells. This is emerging technology. The other one is adverse effects. There are various adverse effects associated with use of chemotherapeutic agent, which is acute as well as delayed over, which can develop with after a long period of time. So the first one is, as you know, this anti-cancer medications has low therapeutic index. That means they can produce very high side effects or toxicity if slight dose adjustment is made. The other one is bone marrow suppression. This increases the likelihood of development of infections due to immune cell reduction. The other one is they affect especially highly proliferating J cells and can induce direct irritation to the esophagus, can induce vomiting, especially drugs like cisplatin, cyclophosphamide, and the different drugs. Majority drugs are associated with this side effect. The other one is hair follicles. So hair follicles especially are rapidly proliferating cells. So transit or temporary alopecia can be caused due to these drugs. The other one is gonadal effect, so they can affect the menstrual cycle and spermatogenesis, and others can be caused by these drugs. The other one is fetus. On the fetus, all anti-cancer medications are associated with teratogenicity because they have cytotoxic effects, so they are not recommended at all. The other one is especially used in children should be used in caution with different management strategy protocol. The other one, secondary malignancy, will be the major issue or challenge, especially with the alkylating agents, as well as leukemia after 10 years, as well as tamoxifen also result in endometrial cancer after some period of time. The other one is hyperuricemia, as we discussed about the 6-mercaptopurine. The increase they can increase hyperuricemia level or uric level, so this increase gout risk. And hypokalemia, hyperphosphatemia are among different side effects associated with the use of chemotherapeutic agents. The other one is cardiac arrhythmia and the nephrotoxicity, especially with anthracyclines, especially cardiac arrhythmia, nephrotoxicity with alkylating, as well as various agents associated with nephrotoxicity. Irritation is the most common side effect among all, especially GI, especially special drug toxicities, especially associated with anthracyclines, cardiotoxicity, pulmonary fibrosis, especially associated with bleomycin, cyclophosphamide, bladder toxicity. So we have already discussed how can we manage these side effects. So peripheral neuropathy, especially with alkaloids and interferon and interleukins and interferons associated with inflammatory disease, because they induce immunity, they can stimulate immunity. That means they can result in inflammatory disease. So let's see how can we manage the adverse effect of chemotherapeutic agents. So the first one is local injection to avoid any adverse effect on the different organs or on different non-tumor cells. So locally we can administer with a limited area, so this can affect systemic side effects. The other one is bone marrow transplantation after treatment. By replacing the damaged bone marrow, we can save the patient. The other one is diuretics to remove or increase urine flow and to facilitate removal of many drugs with low solubility. The other one is folic acid to compensate the side effects associated with chemotherapeutic agents, especially with the methotrexate. The other one is especially the leucovorin rescue therapy. The other one is colony stimulating factor like especially for the neutropenia, so this can prevent any infection. The other one is erythropoietin, so to decrease incidence of anemia, so through blood transfusion and giving erythropoietin, we can save or decrease, minimize the side effect. Thank you for your attention. Subscribe to my channel and like my video so you can get pharmacology related videos. Thank you. See you next time. You can write your comment on the comment section. Thank you.